I would like to thank the organizers for giving me an opportunity. Wonderful conference, and it's really nice to have this midterm conference here, very well organized. So I would be speaking on optimizing outcomes in a multifocal IOL patient. So what is the main goal? Is it just 6 by N6 when you use a multifocal IOL patient? It's more than that. It's basically 6 by happy is what you're going to look at. So if we look at the kind of multifocal IOLs that are being used, a lot of us fear using these lenses because we fear glare and halos, because we fear that if a patient is dissatisfied, it would be as gross as we're having to do an IOL exchange. And yes, the cost is a prohibitive factor. But why do we need to know all this is, yes, with increased life expectancy, there are a lot of younger patients coming to us with surgery who are well informed, have lifestyle changes, and they need spectacle independence. And so in order to cater to all these demanding patients, we also need to be very well aware of what the options we have. Most importantly in these patients is what patient you select, what lens you select. Yes, we also need to do a good patient counseling, and precise biometry and surgery goes without saying. A suitable candidate basically would be one who is highly motivated, comes to you saying that what can you do for me, doctor, because I don't want to use glasses. It's not that you're forcing upon him that yes, we have this option, please take this option, please, that you will not need glasses. This is not the way you should, because the moment you say that, you're increasing the expectation so high that even if he has a 0.5 number and your optometrist says, ha, aapko 0.75 hai, he'll come back to you saying, I was told that I will not use glasses. So you need to have patients who are easygoing personality and have a direct connection with the patient, have a talk with him directly. What patients I personally avoid are those that are hypercritical. You keep tending to ask you 100 questions, very finicky, and if they are regularly doing night driving, long drives, I personally avoid all these patients. So what are the criteria for exclusion? Yes, you do a good preoperative workup. If there's irregular astigmatism, for example, like somebody having a corneal scar or keratoconus, macular pathologies, of course, advanced glaucoma, severe dry eye, large angle kappa, and if there has been an intraoperative event with a large nodular dialysis or a PC tear, we would refrain from using a multifocal lens. Most importantly, I would feel is we do a perfect biometry, and what is important is we also repeat these readings every time for all these premium IOL patients. Ensure that these readings are done even before they are dilated, before an applanation tonometry, because you need a very good ocular surface. That not only helps in giving an accurate biometry, but also you know what exactly the higher order aberrations are. So we also do an ocular surface assessment for all our patients, at least a T-but, look for corneal staining, and look at the OCT also to rule out, because around 10 to 15% of these patients may have a fine ERM, early lamellar macular hole, which can be missed in a dense cataract, and that is why this becomes very important. Management of astigmatism. Yes, like what sir said, what we do is we put it onto the Barrett toric calculator online and see whether the patient needs a toric or not. If it needs, then you tell him that you need a toric multifocal IOL, and also you need to discuss the options, whether the patient can afford it. And yes, laser correction as a second step procedure, but I usually prefer to do it in the first step itself. Now, how to select the lens for your patient is very, very important, because today we are spoiled for choice. There are so many lenses available that what we end up doing is basically matchmaking, which is also very important. So communicate with the patient as to what does he do in his day-to-day activities, and then select the functionally optimum lens for his visual expectations. Yes, we know that we can use both diffractive as well as EDOF lenses, trifocals, and we also need to know what are the limitations of a standard, earlier what we used to use, the bifocal IOL, which is still available now. So you have limited intermediate vision, especially for these patients, reduced contrast sensitivity, and a disabling dysphotopsia sometimes. So whenever you think of these patients, so today our indications for an extended depth of focus has increased when you know what more it can give you compared to a traditional bifocal lens. So you need to know the differences between a trifocal, for example, and an EDOF lens. And an EDOF lens will give you a better intermediate vision, less of glare and halos, better contrast sensitivity, and the kind of neural adaptation and suppression that is there in trifocals would be much lesser. There is a dip in the trifocals between the distance to intermediate to near, which is not there in the EDOF. It's more of a continuous one, and that is why this becomes important. So the extended indications especially in my practice is for computer users, those who are doing night driving, post-refractive patients, or those who have mild comorbidities. You can think of doing the EDOF lenses, but yes, many of them need a reader, so you have to tell them that you might need reading glasses. So how I go ahead is, when a patient wants spectacle independence, 3 questions are asked. First is how much of night driving they do. So if they are doing a regular night driving, then either you use EDOF and you avoid using the traditional diffractive lenses. If they are doing it sometimes, then you counsel them about the glare, and if the glare or if the night driving is very, very high, then that is more important, then you avoid putting it a multifocal at all. If it's acceptable, or if they are not doing night driving, then you can go ahead and then use the second question. So the second question is how much computer work they are doing, because you need to know their intermediate vision. So if they are regularly doing that, either you use a trifocal or an EDOF with micro monovision, and if that is only sometimes, if they are affording, not affording, then depends on that. And if they are not doing any computer work, then you can use, but there are actually a lot of other things also that need intermediate vision. So given a choice, I would go in with a lens which also would cater to the intermediate vision. And also check their reading distance before you decide what is the near ad that you're going to give. Because if it's a patient who is having shorter arms and doing near distance, then that would require a greater addition. So even in patients, precise surgery is also very important. So here was a policeman actually who came to us with a dense brown cataract. We did flax with a multifocal IOL. So what is important is you give a good visual outcome in all these patients. So this was patient 6696 the next day. Now, even though we know that we have done all that we can, if a patient is dissatisfied, then you need to know why. So these are the reasons why you would have a dissatisfied patient. So let's see just briefly. A perfect biometry is essential. So if you have a refractive surprise, first identify where you went wrong, whether you put in a wrong lens, a wrong keratometry, a wrong biometry. Second is a residual refractive error, especially an astigmatism. So whichever lens you use, especially more for a multifocal lens, if there is a residual astigmatism, the contrast sensitivity is going to reduce and the patient dissatisfaction is going to be high. So if you have a residual ametropia and you think that you have done a perfect biometry, first see how much is the residual astigmatism or the residual spherical error. So you can do probably a touch-up or you do an IOL exchange depending on at what point of time the patient has come to you. Posterior capsular opacification, these patients are very sensitive to them. Even if you have folds on the PC, that can actually reduce the contrast sensitivity. So you may need to do an early YAG and a larger YAG. 1 minute left, right? Yeah, but remember, once you do a capsulotomy, then the IOL exchange becomes even more risky. CME is something which you need to detect early because a lot of these patients may have a subclinical one, so doing an OCT would help. Remember to check for the ocular surface and dry eye. If there's a decentered lens, if you remember that if there could be a lens that is not perfectly centered, that itself can induce astigmatism and higher order aberrations. We know that diffractive lenses can cause unavoidable scatter, and that increases the chances of glare and halos. Do not ask leading questions, and if the patient still comes to you with that, reassure that the lens is working and wait, because neuroadaptation will help to reduce their problems. So these patients may take many weeks to many months also, and those patients who are younger, more easygoing and motivated will have faster adaptation. Ensure that the lens is centered well. Angle alpha is important, and you can do this pre-operatively even with the IOL master or with the eye trace. Large angle kappa can cause edge glare effects, and if there are patients with previous refractive surgery, hitting emetropia may be difficult, and because of raised higher order aberrations, that can cause more night vision issues. So basically counseling is very important. Give them realistic expectations. Do not give them 100% guarantee that they will not need to use glasses at all. So undersell and over deliver. Special consent we usually take for all these patients. More chair time pre-op is always better. Thank you so much.